Now that you return from your small break, we're going to talk about testosterone, and we're going to have a couple presentations that I divided up. Testosterone in men, we lose 1 to 3% of total testosterone starting about age 30, and by age 50, all of us have lost at least 50% of our productive capabilities. So that's important because of the fact that when you go to your doctor and you get your testosterone measured when you're 50 or older, and they say, well, it's 400, that means it's okay. That's not where you were when you were 30 years old, because at 30 years old, you can double that. The number you needed was double that number. So the real normal is probably 800 or above. And to be functional, you have to be returned to that level. So don't buy into the fact that just because it's 400 and it's in the range of normal that it's okay, because you're trying to make this patient functionally normal. Likewise, in women, by age 40, they've lost 50% of their testosterone production. That's why their muscles don't respond to exercise. That's why they complain of that gut being developed. As men do, they start developing that beer gut, and women start developing muffin tops, and ultimately it results in what I call the menopausal tire or menopausal Michelin. And women, unlike men though, lose the last 50% within about a 10-year period of time. As soon as they go into menopause, they've lost about 98% of their testosterone production. And that puts their breasts at risk, because that's when the incidence of breast cancer basically jumps from 0.5% to 10% or 11%, depending on who you read. So that 20-fold increase is explained by testosterone deficiency, and the 10 years in which we go from 40 to menopause, they're getting fluctuating levels of estrogen. So fluctuant levels of estrogen, which are no longer in the right ratio, and the absence of that protective hormone testosterone induces nodules and cysts to develop within the breast. And so therefore, no wonder that women, when they turn 50, their chances of breast cancer skyrocket. In addition, there is a significant change in the balance of weakly bound or free testosterone and tightly bound or SHBG bound testosterone, because when SHBG binds onto testosterone, forget it. That molecule is no longer functional. And so what happens is you get more testosterone as being bound by that protein, and the free or weakly bound or usable testosterone decreases. One thing that we have to make clear right at this very moment is that there is a difference between synthetic and human testosterone. The anabolic synthetic steroid, 17-alpha testosterone, you cannot be aromatized and causes all sorts of problems with lipids, such as low-density lipids, the LDL, the VLDL, and it decreases LDL, and it causes the problems in the human system that puts the patients at cardiovascular risk. That's why you see these professional wrestlers, the football players that juice up, the bodybuilders that juice up. All of a sudden they're going into steroid rage because their brain is starting to liquefy. They develop liver tumors because of this synthetic testosterone, and they develop cardiomyopathies because that 17-alpha nucleus is cardiotoxic. 17-beta testosterone is cardiobeneficial. It's what the human body produces, and what our bodies produce cannot be harmful as long as it's being put back at the right physiologic amount. And that's the beauty of using the formula that we're going to teach you later in this session. In the study done, in this study, elderly patients who had documented coronary artery disease were given 17-beta aromatizable testosterone, and the total cholesterol and triglycerides decreased and the HDL increased, therefore protecting that arterial system. even in patients who already had a damaged arterial system with that precipitated coronary artery disease. In this study, men aged 56 and older were given intramuscular testosterone enanthate, which is unavailable in the United States and is an aromatizable testosterone. And once again, in these patients, the total cholesterol went down. The ratio of HDL to cholesterol and triglycerides also was reduced and improved, and the HDL basically remained stable. As you may have read and seen, and you certainly have seen on TV now, that lawyers are coming out saying, if you got testosterone and got a heart attack, you need to call us so that we can sue whoever it is. Well, what are they using in that study that they're quoting? They used synthetic testosterone. They did not use aromatizable testosterone. In 24 years of using this form of therapy, I have not seen a heart attack or a stroke in a patient. And we're talking about hundreds of thousands of implants. So Zmuda, when he published his studies in American Journal of Cardiology and Atherosclerosis, he found that men given aromatizable testosterone, that their alpha lipoprotein decreased, which is markedly beneficial, and that the substance that causes inflammation that precipitates plaque formation in the artery, called homocysteine levels, were not changed in any way. Whereas unfortunately with 17 alpha, that's one of the main things that happens, is that homocysteine levels are elevated, therefore increasing inflammation within the human body and especially in the arterial system. In this study by Weyrich, which was a monkey study, basically he found that there was no direct association between exogenous testosterone usage and coronary artery disease using an aromatizable testosterone. And Thompson found that there wasn't, when you use this form of therapy, that there's no direct cause and effect relationship between using of these androgens and coronary thrombosis, and that the role of supplementation and replacement with androgens remains undefined as of that time. Subsequent studies done by Susan Davis has shown that the impact on, and Morris Notilowitz as well, has shown that there is no negative impact on clotting studies in any way, shape, or form. Anabolic, non-aromatizable androgens can basically have direct toxic effects on the heart muscle in monkeys and rats. We know that. Why they would use a synthetic testosterone in those studies at the Veterans Administration hospitals, and then expect anything but bad results in that very poor health population. The folks who go to VAs are uniformly the unhealthiest individuals in the entire world. They usually all smoke. They're usually have experienced alcoholism and liver damage and high blood pressure. They are cardiovascular accidents waiting to happen, and to give them something that might increase clotting factors, those doctors their feet should be held to the fire. Anabolic androgens have also been shown to cause vasoconstriction and vasospasm in coronary arteries in all experimental models. So once again, why would you give someone who has a compromised cardiac status something that may cause constriction of their coronary arteries, which would then precipitate a heart attack, or cause a stroke by causing vasoconstriction and then a clot formation in the arteries in their neck, which are probably already full of plaque. In a number of studies, aromatizable testosterone has actually shown the opposite. It's actually shown that it can actually add to the pliability and the elasticity of the coronary vessels. And if you keep those vessels pliable and elastic, they basically then can adapt to the need, say, during exercise of increased blood flow through there, whereas when you have plaque in there, it's like a rigid pipe. And what happens then is that you get restriction of flow, you get loss of blood to that heart, it decreases its oxygen supply, and you cause a heart attack. Simon in his study showed that there was metabolically, Testosterone has very beneficial effects on the human system because it helps you control blood sugar and insulin levels. And he found in healthy men with low testosterone, they had increased insulin levels. When you increase insulin levels, you increase the chances of increasing triglycerides, total and the LDL, bad cholesterol, as well as the alpha lipoprotein, which is this is a bad scenario for your arterial system. Likewise, you get marked increase in fat deposition because increased insulin levels make you turn your carbohydrates into fat, and that gets deposited in your abdominal area for men. For women, it gets deposited circumferentially, and then they become insulin resistant. And insulin resistance can lead to metabolic syndrome as well as diabetes mellitus type 2. So having low testosterone predisposes the human male and female to the development of the changes that could lead to diabetes and all of its attendant morbidities, such as high blood pressure, obesity, renal damage, and possibly heart attack and stroke. So in women and men, androgen replacement therapy should have the goal of reproducing steady physiologic levels, because if you don't reproduce those levels, then and you spike it like you do with injections or with topical application, you don't get the beneficial effects, because the hormone needs to be there at the right amount, at the right time, and it needs to be there continuously for it to give you beneficial effects. When you spike it, you get exactly the opposite. You get adverse impact on your cardiovascular and your lipids, and also on fat deposition. On the slide that basically shows the positive effects of bioidentical testosterone, if you look on the male side and take away the top two, the improved erectile ability because of increased blood flow production and increased prostate production, because testosterone protects the prostate, as has been shown at Harvard University by Dr. Morgenthaler. All the other symptoms are identical for men and women, especially the things such as reduced body fat, stronger bones and muscles, lower cholesterol, and better cognitive clarity. Testosterone is the main hormone that stimulates the parietal and temporal lobes of the brain, as well as the frontal lobe. Those first two lobes help you focus, concentrate, maintain short-term memory, allow you to problem solve and multitask as easily as you did when you were in your 30s. And as we age and lose our testosterone production for both men and women, it's not unusual to become you start getting more forgetful, you forget why you walked in the room, you start reading scientific data, and by the time you get to the middle of the page, you've lost your train of thought, you've lost what you've just learned, and you have to go back and reread it because of the fact you can't retain it. And that's in that short-term memory, and that's testosterone dependent. Dosage is critical in testosterone. That's why the dosing formula is so important. And basically what this shows is that the higher the dosage, the better the testosterone levels, and that's just natural. What we see on the second slide of plasma LH and FSH is that you get suppression of both those hormones, although in males the FSH suppresses more than the LH does. And although it seems equal on this slide, in actual practice, we found that measuring LH levels is almost useless because you don't get that marked suppression of LH, even in patients who come in with very low testosterone, like in the 100s, their LH may still be normal. So, we do know that the FSH suppression occurs rather routinely, and so in younger patients, those patients who are still trying to get their significant other pregnant, using any form of testosterone therapy may basically threaten the ability to generate pregnancy, because the FSH stimulates sperm production. And so therefore, in those younger individuals, and this is a tip, use Clomid, 50 milligrams a day. It will do two things. It will raise the FSH, which will enhance sperm production, and it will also increase LH secretion, which will then increase the testosterone, albeit just for the time that they take the pills, Once they get their significant other pregnant because you've increased their sperm count and that pregnancy has gone to, into the second trimester, then you can discontinue the Clomid and use pellet therapy on that individual. Roden and Morgenthaler published a landmark paper in 2003 because they wanted to see if testosterone really caused prostate cancer. And what they found is that they took men with precancerous tissue, divided them into two groups. One group they did nothing but observe. The other group they gave them testosterone therapy in injectable form, by the way. And what they found is that there was no difference in PSA or in the occurrence of prostate cancer in the group of men that got testosterone therapy. The thought was, if testosterone causes prostate cancer, then that precancerous cell will become cancerous as soon as testosterone is inserted. And what they found is that exactly the opposite happened. There was no difference between the two groups. And therefore, since that time, they have basically taken the stand and turned all of these thoughts around 180 degrees, because now we know that testosterone replacement therapy isn't contraindicated, and even in men with precancerous tissue in their prostate. So don't fear that the testosterone you're giving is going to increase the incidence of prostate cancer in men. It does not. Stratton likewise found that high testosterone levels don't increase prostate cancer risk. Think of it. How many men do you know that are 30 years old or 35 years old that have prostate cancer? That's like finding teeth in chickens. It would be an absolute rarity. Because high levels of testosterone, meaning high normal levels, high levels that a 30-year-old man would have, protects the prostate. Not the low normal levels that men who are in their 50s, 60s, and 70s maintain. That does not protect your prostate. Shostak showed that all different androgens and sex hormones are not related to the risk of developing prostate cancer. So this brings us to pellet management and dosage for men and women. And in this, it kind of gives you a little background as to why the dosing formula is so important. First of all, we've always been diagnosing people as having with symptoms: hot flashes, moodiness, not having periods, husband complaining, wife not wanting sex, and men not being able to generate erections. And we've been treating it traditionally by changing the color of the pill or the size of the patch, or in men giving shots and patches and topicals. And all of these may help with some symptoms, but they don't do anything to make the patient physiologically normal. So if you're going to make that diagnosis adequately, the tests that you see on this slide should be your core testing. And that means looking at thyroid as well. So in women, total testosterone is the only reliable test that you can use, and even that is not that reliable. We're going to talk about how to interpret that data. But free testosterone is completely erroneous in its results because of the low levels that women produced in comparison to men. Total testosterone and free testosterone in men is accurate. In women, you're going to find out that those assays were meant only to be used in men and not in women. So we've been telling women that they're normal when in actuality that standard has not been established. In men, we want you to check the thyroid, but also we want you to check the estradiol. And I'm going to show you later on exactly why this is important, because you need to know how much that testosterone in men is being converted to estrogen, and it should be less than 2%. In men, the testosterone assay of total and free is genuine, because of the fact that the assays are accurate to 300 nanograms per deciliter. Unfortunately, women and children live way below that. So therefore, that's why the assays are unusable or inaccurate, unreliable, below a level of 300 and should only be really utilized in men. The PSA, the hepatic and metabolic panel, and CBC are necessary because so many men do not go to doctors routinely. In women, the correct interpretation of the FSH is basically critical, and that's why it's one of the more dominant variables in the formula. How we interpret those, is what is important, and that's what the formula does for you. The usual FSH values in women are basically universal. The FSH kits and assays that they use in China are the same ones we use here. So if you get FSH levels on Chinese women coming from Shanghai, they're going to be as valuable as they are here in the United States. And once again, remember, you use FSH because it's the peptide hormone that basically tells you about the physiologic status of that individual. So you have to have an FSH level before you treat. If you don't, and if you don't look at it afterward, you don't know you cannot assess, and you do not know whether you have made a physiologic impact on that patient. And the goal in women is to produce a premenopausal FSH, which means in the 20s or below. So why is that important? The importance of that is, number one, the higher the FSH, the more symptomatic the individual. And so therefore, if you are thinking that basically it's unimportant, it is the most important variable to determine what the estrogenic activity is and has been in that human body over weeks, 2 or 3 week period of time, not just when that needle is in the arm. So the higher the FSH, the more physiologically deficient that patient has become. And what the FSH does is that it gives you an appreciation of that deficiency, and you can't determine that in saliva. I'm sorry, all the saliva gurus, they are wrong. It does not. Saliva estrogen levels are worthless without an FSH. And why would you have somebody spit in a bottle for a day and then draw blood? You might as well get it out of the blood, because when you compare the estrogen levels with the FSH, you have a tremendously correct evaluation of that physiologic state. So you need to think of it, the FSH, as being like the hemoglobin A1C and blood glucose. It tells you how that patient's estrogen activity has been over a period of time, whether they're taking estrogen or they're producing it internally. As an example, this is an actual woman. She came in to see me, brought in lab work that was done at 1 p.m., showed an estradiol level of 92, but she was having hot flashes and moodiness, and her doctor told her, well, your estradiol is 92, so you're normal. So I sent her back to get her blood work exactly at 1 p.m., but also I ordered an FSH. And as you can see, the FSH was almost 92 as well, which means really, when you get used to using the formula, that actually her actual FSH without pills was probably well above 100, but yet at a level of 92, which has spiked at 92, she didn't get continuous enough suppression of the FSH to be normal. And we gave her pellets, her FSH dropped to 25, and all her symptoms were gone. This is a common thing that you will see in all of your patients. I had a patient just the other day that came in that has been on oral forms of estrogen, specifically Prempro, and her FSH was 111. So, and she went into menopause prematurely, and so even that small dose of Prempro was markedly insufficient to bring her to physiologic normality, and you're going to see that time after time. So what will happen, and what you'll see time after time, is that our cohorts and our peers out there forgot that FSH is necessary, and so you may get a lot of lab work sent to you that doesn't have an FSH, and believe me, you're going to have to send that patient back out for an FSH, because that's the only way of telling whether or not that estrogen level is normal or abnormal. A special case is patients on oral contraceptives. Oral contraceptive patients traditionally have FSH levels that are 5 or less. That's the beauty of using birth control pills. It suppresses the FSH because of the high estrogenic index in the estrogen in birth control pills. And so therefore, if a patient comes in and says, I can't sleep at night, I'm getting some hot flashes at night, and I'm having problems, well, her pill is wearing off at that period of time, and so her FSH is tracking upward. And so if you measure an FSH of 5 or higher, then, and they're symptomatic, that means they need estrogen. And those patients who are maybe like in their mid-40s or so that are on birth control pills because they are terrified of pregnancy, or they're on it to control the amount of flow in their menses, or they're on it because of control of symptoms and they're not getting that, you can give that patient like 6 milligrams of estradiol, and you would activate in the formula the menstrual migraine variable, and it will tell you the correct dose for that patient, and you will have a patient for life because you will elevate their estradiol to probably just 10, but they will think that the world has completely changed for them, and it has. So the estradiol pellet basically maintains that estradiol ratio of 2 to 1, which I've basically beaten into your head telling you how important it is. And also, don't buy into estriol, because estriol is a breakdown product of 16-alpha hydroxyestrone. And basically what happens is that you're talking about something that could live basically in balance with that carcinogenic estrogen. So estriol is not breast protective, which is why the FDA will not allow anyone to basically promote that, because estriol does not protect the breast. In fact, is in high doses, it may wind up being estrone. So the goal of pellet therapy is to turn that physiology back to normal, which means giving an FSH that's in the 20s or below. And the only thing that can do that is the continuous production of physiologic levels of estradiol through pellet therapy. So now that we've visited that, let's talk about testosterone and the facts about testosterone. I said we would do this in 2 parts. Number 1, the signs and symptoms of testosterone deficiency, other than if you see the loss of erectile ability, is the same for both men and women. In testosterone therapy, you never want to use a synthetic hormone. We've talked about the dangers of that. Biologically, 17-beta testosterone is the only choice, because it reduces the possibility of developing these unfortunate adverse reactions. Can you get abnormal hair growth or acne with biologically identical testosterone? If you don't use the dosage formula and you don't use blood work, yes. Because anything, even a good thing done to excess, is going to have adverse complications. So using the dosing formula will keep you out of that problem. And pellets are the only thing that recreate that physiologic level of testosterone that is necessary in both men and women. Why? First of all, pills are synthetic. Nobody uses pills anymore, except maybe a biologically identical sublingual lozenge. But with synthetics, especially in the oral form, there's a high degree of liver toxicity. And with injections, especially high doses, liver toxicity. Synthetics also raise that SHBG, which is a protein that binds testosterone, and therefore it limits the amount of usable testosterone. Think of it as this. The synthetics are like the IRS coming in and locking up your bank account by producing more SHBG. And if you're left with just $20 in your pocket, that's all the usable money you have. So therefore, raising the SHBG basically is like the IRS locking up your bank account. You can't use any of what you're making. Also, by using synthetics, it stimulates excessive aromatization. And what does that endanger? High estrogen levels increase fat deposition, blood sugar levels, high blood pressure can be generated, as well as in males, prostate growth. So if you're using synthetics, be prepared for that problem with the prostate. Whereas with 17 beta, if you pay attention to what I teach you, you will not have that problem. The nice thing about using biologically identical is also is possibly in the patient who is not a candidate, you can use a sublingual form, but be aware you may get the roller coaster effect, which they're trying to avoid altogether. When you're using creams and gels, especially in men, asking them to put the cream on, once a day, or using more of it. If they're trying to rush off to work, or you get much poorer compliance with males than you do with females. And what, unfortunately, the pharmaceutical companies don't tell you is that the topicals will develop a receptor site insensitivity, meaning that basically the more you use it, the more you put on, the more insensitive your body becomes to it, and you find yourself having to use more, which is why they keep increasing the concentration of Androgel. Now it's at 1.62%. It used to be 1%. Because of the fact that increased resistance in the receptors also is produced by the elevation of the SHBG over the long term. The pellets don't increase the SHBG. They have little impact on the hematocrit, except for the patients who live at high altitude. So in our practice in Arizona, those folks that live in Prescott, which is about 5,000 feet above sea level, or Flagstaff, which is 7,200 feet above sea level, and those folks who live in Utah or Colorado or any of the mountainous areas, like mountainous parts of California, you have to watch their hematocrit, because they walk in with higher blood levels anyway. The real problem with males is that if you don't limit their post-insertion activity, they can expel those pellets. And in the literature, it talks about a 7% extrusion rate, which is, basically absent in our practice. So what's a normal female level? Remember, we talked about that. The problem with the assays is that as they publish, and I must have been one of the few people who read this article back in 2002, is that the assays are unsatisfactory because of their lack of sensitivity or reliability at the lower ranges of normal. Remember what I told you. Assays for testosterone are only accurate to a level of 300 nanograms per deciliter. Even the new assay, they tout it as being wonderful, the LC/MS. It's not. Above 40 is completely useless. So using it in males, you're going to get erroneously high levels. So don't buy into that. So this consensus statement on female androgen insufficiency was generated out of Princeton University by a number of people who are experts in androgen therapy in women, such as Rogerio Lobo, Susan Davis, and the like. So look up this article if you have any doubts about that. And basically what you're going to find is that what we've been telling women is normal is absolute bunk. So what are some of the things that you have to think about when you're thinking about what could be causing these symptoms of androgen insufficiency? Think of thyroid disease, the chronic fatigue syndromes like Lyme disease, chronic fatigue itself, fibromyalgia, any metabolic or nutritional deficiencies such as diabetes, etc. Psychiatric disorders. Someone who is basically schizophrenic or who is being treated for psychosis, avoid them like the plague. Don't treat them with testosterone. Don't think, unless you really can document it, that it's going to be beneficial. Other endocrine problems also can mimic that, and you have to make sure that none of those other areas are present. So diagnosis may be tough then. Out of this same article I quoted earlier, the sensitivity assays and the absolute threshold values of androgens have not been established for women. This is the conclusion of that opinion paper, and it's still true today. Even in the literature from called clinical chemistry, the same. They looked at all 10 assays, and none of them had reliability or sensitivity accurate enough to accurately diagnose insufficiency in women and in children. So how much testosterone are you talking about? Well, let's look at premenopausal women. How much do they make? Because this is where you want to return the patient to a premenopausal level. And women produce 300 milligrams every day if they are normal. So that premenopausal woman who's above 40, who is producing normal amounts of testosterone and has perfect exercise tolerance, has fast recovery from exercise, doesn't putting on fat, her brain is working in a superior fashion, and she has great bone density, she's producing 300 milligrams a day. 300 milligrams a day is equivalent to 30,000 nanograms, because in the United States, the most common unit of measure is nanograms per deciliter. And 30,000 nanograms is equivalent to 10 to 15% of normal male production. So when you're measuring, so if you want to find out what really is normal for women, you take the male numbers, this male upper limit of normal, the upper range of normal, the upper 1/3 of the range of normal for men is between 700 and 1100 nanograms per deciliter. And in some labs it's even a little higher, closer to 1200. And women therefore are entitled to have 10 to 15% of that serum value. So therefore, when you multiply out that equation, which you see on the bottom line, it comes out to be that true normal is 70 to 150 plus or minus 10%. That's what real normal is. So therefore, we've been mistreating women because we've been looking at these faulty values and saying, oh, your lack of libido, your lack of energy must be depression, or you can't lose weight because you're eating incorrectly. Bunk. It's none of that. It's the fact that they can't generate normal metabolic rates. They're having problems with stimulation of their frontal lobe so that they don't have drive, motivation, or the libido that they once did. So how do you make the diagnosis? In women, it's total testosterone. In men, it's the usage of total and free. If you want to measure SHBG, you can waste the patient's money because of the fact that even if it's elevated, you can't do anything about it. The free testosterone is going to tell you whether or not they have too much SHBG in their system. In total testosterone in women, as the symptoms get worse, even though they're in the normal range, which is what this shows. So what if your lab gives you a combo package of total and free testosterone? In men and women, if you want to use the free testosterone, take the midpoint of that normal range, and anything below the midpoint of that range means that patient is androgen insufficient. So that's how you use free testosterone. In men, I use it as my determining factor. If someone is somewhere in the middle of the range of their total, like between 450 and 550, but their free testosterone is really low, then I treat them. If their free testosterone is normal, then it may not be a testosterone insufficiency for them. What's the optimum level? Well, in males, the closer you get to 1200, the better off we are, because that's where we were when we were 30. How do you detect? Remember we talked about aromatization and how you would check that. Because excess estrogen production, especially in males, precipitates weight gain, blood sugar elevation, possibility of insulin resistance being increased, as well as prostate stimulation. So you want to keep that estradiol to total testosterone ratio below 2 to 3%. If it's 3% or higher, you need to treat the patient with an aromatase inhibitor. And my recommendation is to use letrozole. That's Femara in brand name. But you get it in generic in letrozole, and it's about $2 a month. 2.5 milligram tablet, a half a tablet twice a month. Why is that? Why do I use this one? Why do I recommend it above anastrozole, the second one? Because it has dual benefits. It increases LH release. We found that because they were using it in infertility treatment in women. The LH release being increases the internal testosterone production, therefore limiting the amount of testicular shrinkage that might come from testosterone therapy. So use this without hesitancy, because of the fact not only does it inhibit the aromatase enzyme preventing estrogen from being produced, but it also increases the internal production or maintains the production of testosterone from that individual. Therefore, stimulating the testicle twice a month to activate and produce testosterone prevents testicular shrinkage. Our anastrozole or Arimidex does not have that LH release function. It can only inhibit aromatase. And the cost of anastrozole is about twice as much as letrozole because you have to use twice as much. You want to watch your step on the emotional or psychiatric patient, because if you don't feel comfortable when they're sitting there talking to you that they're basically in a normal state, then you don't want to use that pellets in that patient. Patients who have fibroids or dysfunctional uterine bleeding, that patient, you make sure that diagnosis, if they're having dysfunctional uterine bleeding, you got to know what is causing it before you treat them. In women with fibroids, there is a special variable in the dosage formula that you activate that will alter the estrogen dose for those patients. Breast cancer survivors, the same. There is a variable. The things you really have to watch out for in women who have a uterus is a non-compliant patient who doesn't pay attention to your instructions on how to take progesterone, because it will cause breakthrough bleeding. The mistakes that are usually made with progesterone is that a lot of people don't listen to what I say. When you use pellets, you have to use certain dosages, and we'll talk about this very shortly. The most common cause for breakthrough bleeding and progesterone mistake is the patient doesn't take it correctly. And then that causes bleeding. And then bleeding means evaluation, and then that triggers treatment. So, when you're using progesterone, some suggestions. Very important, if you're getting it compounded at a compounding pharmacy, make sure that they do the instant release progesterone, not sustained release or slow release. Instant release gives you better protection for the endometrial lining. Something that allows the patient to she can maybe make a mistake and doesn't pay with breakthrough bleeding. Whereas with the slow release or the sustained release, the body doesn't have that capability of forgiveness. If you're using a dose of estradiol that is 10 milligrams or less, you can use 100 milligrams of progesterone. Extremely important. If you're using an estradiol dose of 12.5 or higher, use 200 milligrams. Don't be chintzy, because all it's going to wind up with is half of those patients are going to be calling you about spotting and bleeding. So don't think that 200 milligrams is too high. It's not when you're using an estradiol dose of 12.5 milligrams or higher. What are some of the problems of first insertions? Because the body for the first 2 weeks is going through a significant transition physiologically, the body will tend to want to retain fluid. So you can get swelling of the hands and feet, more common in hot and humid conditions. You can get breast tenderness and nipple sensitivity. Please let me tell you that I have avoided nipple tenderness and sensitivity by having all my female patients take oil of evening primrose, either in 1,000 milligram or a 1,300 milligram dosage. It's eliminated that completely because of the fact that it has an anti-inflammatory effect, which when coupled with testosterone eliminates that. There might be uterine spotting or bleeding of very short duration, doesn't mean much of anything. And mood swings and irritability might be because of the transition, and they may get a small facial breakout. In conclusion then, if we're talking about the benefits of pellet therapy, it keeps that estradiol to estrone ratio 2-to-1. You only need to retreat it every 4 to 6 months in females and in males. It has a greater safety margin than any other form of delivery, and it's adaptable to treat other significant conditions such as postpartum depression, menstrual migraine, etc. Certainly, the treatment of osteoporosis is extremely successful, especially you can use it in patients who have esophageal reflux disease. It improves the lipid profile. There is no adverse impact on coagulation because it does not use the first pass metabolism of the liver.